Maki.
Terrific. Thank you very much. Thanks very much for the opportunity to speak today. We'll talk a little bit about the meeting just a few weeks ago in Dublin. It's very, very good turnout from patient advocates. And in fact, I think there's something like 60 different groups had representatives there, if not more. So that was very impressive to see really the whole world come together in that sense. And in a similar way, the scientists and the clinicians were also together and presenting at least a little bit of their data. A lot of the data end up being, I would say, these are kind of more preliminary sorts of studies for the bigger meetings that will occur over the course of the year, the AACR meeting, the ESMO meeting, and ASCO meetings for some of the science stuff and the clinical medicine. But at least we got some hints of some interesting things. So just go over some of those today, and just kind of broke down the different abstracts, and really only a couple of oral presentations on leiomyosarcoma specifically, just into these topics. So the last, actually, just the first couple of slides are on some of the biological principles that people are working on, and after that, it's really kind of a description of what happens to people over time with their leiomyosarcomas, and sometimes mixed in there are some other forms of sarcoma as well. We'll mention some of the early clinical trials results that were presented, and then a couple of new combinations which are being examined as well. So in terms of the biology, we'll start there. Dr. Brito, I think, is in France, if I remember right, and the work they were doing, which I thought was very interesting, is they took smooth muscle cells and stuck those together with fibroblasts, which are just normal connective tissue cells. And number one, they were able to get some kind of two nucleus fusion product from those things, and they also saw that some fraction of those cells developed mutations in a very specific gene, which is listed here, this PRKG1 gene. And they saw that repeatedly, so they figured, okay, well, let's go take a look at some leiomyosarcomas and see if we find this gene at all. And indeed they did. They found it in about 14%, 1 in 7, roughly, leiomyosarcomas that they examined from some databases had this mutation or deletion. And when you didn't have this gene, the cells tended to not stay in place. They wanted to go elsewhere. They would tend to move more, and maybe that's the reason that they're associated with a metastatic phenotype potentially, and people who had low amounts of this gene did worse. So if they can figure out exactly how this loss of this gene leads to activation of the ability of these cancer cells to crawl around, that'll give us some potential targets for trying to slow down the metastatic process. So it was a very, very nice one. I thought the science posters or talks were very good. This is everybody's excited about immunotherapy, and as you all know, folks with leiomyosarcoma tend not to do as well with immunotherapy as people with a few other diagnoses. And Dr. Feng and her colleagues who work in Alberta and Calgary took a look at some data sets that they had of their own, and then also some larger data sets, which are these international consortia databases of several hundred, or in some cases thousands, of cancer samples, some of which are sarcomas. And as has been shown in some previous work, they did find evidence of at least a few leiomyosarcomas that had evidence of an active immune, so-called tumor microenvironment, TME. And that it didn't completely overlap with other criteria that we've used in the past, these sarcoma immune classifiers, or the SIC. They found some different features from their work that may indicate activation or not of the immune system within a leiomyosarcoma. As we begin to tease these things apart, even sometimes cell by cell, we'll begin to get a better understanding of who may or may not respond to the immunotherapy drugs, which are working so well in diagnoses like melanoma and bladder cancer, for example, and non-small cell lung cancer. So their request, and actually it's already been taken up by the French as well, is to make sure that you stratify the patients that you put on immunotherapy trials. Use those classifiers where you can. Try and get materials from patients. You can assess some of these things even from pre-existing tissue and paraffin blocks that have already been taken out of people. You don't have to do a biopsy to confirm at least some of these markers. And if that's the case, then you may have we'll learn more about who will benefit and who won't benefit from immunotherapy. The other really interesting bit of biology was this particular poster. And this took a look at the idea of what happens to the leiomyosarcoma cancer cells themselves once you poison them with chemotherapy. And so people have done this to some degree, but I'm not sure that they've done quite so careful an analysis as was done here. And we actually even will see this sometimes when people go to surgery after having gotten chemotherapy for their sarcoma, leiomyosarcoma in particular. And so what they did here is they took 4 different types of cell lines, leiomyosarcoma cell lines, or growing those, and they exposed those to chemotherapy. And you can give them graded amounts of chemotherapy to hopefully trigger cell death in those. Or if you're at some intermediate level, you'll see that some of the cells get damaged, but they somehow keep growing. And they showed here that if the normal cells are on the left, or the normal, if you want to call them normal, leiomyosarcoma cells, once they're treated, they give you something that you see more in the middle here. And they're much bigger, obviously, than the cells that you see all the way on the left. And what's happened is that they may have reduplicated or reduplicated. They've massively increased the amount of DNA in their nuclei. And they basically have reduplicated all of those 46 chromosomes, or however many they're carrying around. And that may be another mechanism by which some of these cancers can become resistant. The little graphs on the right there, the green bars show that as you expose these leiomyosarcoma lines to chemotherapy, you get more of those green peaks. That means you've shifted the amount of DNA that's found in the cancer cells. And the mechanisms by which this happens, number one, and number two, what that means for sensitivity or resistance to chemotherapy is something they'll work on. We see this in a number of different cancers where you'll see this reduplication of the genome, and it really has not been worked out well for many of them. Why? It may indicate resistance to chemotherapy, but it's a nice starting point, and I think this is something that really will yield some nice information. The really interesting thing was that I think cells don't like to have too much DNA around, and what happens to these cells, they could demonstrate, is that bits and pieces of these giant cells, as they're called, sort of fell off of, or budded off, as they call it, from this bigger giant cell in the middle, and those looked more like the cells on the left, but now they were resistant to chemotherapy. So again, step by step, we'll hopefully understand the mechanisms by which this happens. How do these cancer cells talk to one another and protect themselves from the chemotherapy that we're giving to try and kill them? And then the last, I think it's the last science paper where, again, they took a look at some leiomyosarcoma cell lines, and again exposed them to chemotherapy, but then also exposed them to the so-called PARP inhibitors. It seems like there may be some problems with leiomyosarcomas, at least some people, in reproducing their DNA effectively. And one of the Achilles heels of some of these tumors may be something we can target with those drugs that you see in the second row there, olaparib, niraparib, talazoparib. And they showed that in many cases, the drugs were additive, in some cases synergistic, and they showed that 2 combinations in particular looked useful, as either doxorubicin or temozolomide, an oral medication that looks a lot like dacarbazine, an intravenous drug we give a lot for leiomyosarcoma. And they showed that that combination of either the doxorubicin and talazoparib, or temozolomide and talazoparib, those gave better ability to kill cancer cells, at least some of the cell lines they were studying. How artificial those cell lines are, remains to be seen. That said, not presented at this meeting were some data on the combination of temozolomide and a PARP inhibitor, and there appears to be some activity of that combination already. The next group of posters had to do with just how people do, how long do they go on after they get chemotherapy, what are the risk factors for these tumors in terms of how frequently they come back. And William Seng, who's been out at USC, just basically classified a large number of leiomyosarcomas from a large database that he had. And he showed that a lot of these come from branches of the vena cava, the big vein that drains into the heart and drains the blood out of the legs into the heart. And then similarly, the superior vena cava, which drains the blood from the head and neck and from the arms back towards the heart. At least for the abdominal tumors, a lot of these came from branches of this largest vein in our body, which has smooth muscle in it. We need that smooth muscle in these veins, otherwise you'd go from lying down to standing up and blood would pool and you'd faint. So every vein in our body has a little muscle in it. And those are, we think, oftentimes the source of leiomyosarcomas, especially in the extremities, and then, as Dr. Seng showed here, from some of these even larger blood vessels, like the vein that drains the kidneys, or those that drain the liver, for example. And he talked about how some of these patients got chemotherapy and some got radiation prior to their surgery that he often performed himself. And he showed that only the bigger tumors, when they were 11 centimeters, basically 4 or 5 inches in size, and if they're the highest grade, that those predicted for metastatic disease. So it may provide some information about when you'd think about giving chemotherapy in the adjuvant setting. In other words, after the tumor's been cut out, to try and prevent the darn thing from coming back. So that was a nice study in that sense. The other interesting study I thought was this particular study, which they took a look at people who had Leiomyosarcoma syndrome, LFS, and some of those people who have the gene P53 gene mutated in every cell of their body. Those people are prone to developing any number of cancers, including leukemia, breast cancer, cancers of the adrenal glands, and it turns out that sarcomas are amongst the most common cancers in patients who have Leiomyosarcoma syndrome. And it's not unusual for some people with Leiomyosarcoma syndrome to have 4 or 5 or 6 cancers even by the time they're 40. So was there anything different about the leiomyosarcomas that they saw in people who had Leiomyosarcoma syndrome versus those who just had them arise sporadically, just randomly? And they were able to find 30 people who had familial syndromic leiomyosarcomas, and show that they may live a bit shorter period of time but interestingly, they may also provide fewer metastases. So exactly what is causing people to die? Is it necessarily of their sarcoma? Maybe not. Maybe they're developing other cancers as well. So it was pretty impressive that they found 30 people with this exceptionally rare syndrome. I think there are only a few hundred families affected in the United States with this particular familial condition. And so it's great they were able to gather some data. Now they'll be able to take a look at some of the genomics in more detail to see exactly what's different about these tumors compared to the ones that arise randomly. All right, then moving on to some of the standard treatments. A lot of these are chemotherapy studies. And there are 2 studies which took a look at the question of how well do you do when you get your first treatment versus your second treatment once the leiomyosarcomas come back. The 2 studies were from the UK and from Canada. And it's interesting because the situation is a little bit different in the 2 countries. In this group from the UK, nearly everybody got doxorubicin first if they had metastatic disease, and then they frequently got gemcitabine and docetaxel as their second type of therapy. Some people got ifosfamide. And you see that people, this is why we're doing research, is that people don't do well for very long. On average, people only stay on the medications for 4 or 5 months before they're worse, and only about 1 in 6 people will get the so-called partial response. That's that nice scenario where the tumors shrink by 50% or more. It's a pretty high bar, and that's why that number is so low. And this 39 or 34% for stable disease actually includes a number of people who had minor shrinking of their tumor, sometimes for a prolonged period of time, but they just never met those size criteria that qualifies a good partial response. They also didn't see any. The other disappointing thing here is just didn't see any complete responses. That's a pretty uncommon thing with leiomyosarcomas. And but you see here that people who got second-line therapy had about the same chance to have a good result as people who got their first-line therapy. So these drugs do work independently of one another, and I think this is nice proof that Yes, you have a second shot on goal, as it were, if the first treatment didn't work. There were the other drugs besides these, the ifosfamide that was useful, trabectedin as well. But it's interesting that there were no data on pazopanib, Votrient, which is used a lot in the United States because the drug just isn't available in the UK without an active the House of Lords or something like that. It's very difficult to get the drug there. It's not been approved by the so-called NICE NYCE committee that evaluates the cost effectiveness of treatments. Meanwhile, over in Canada, they had a nice study here. This is a slightly larger group, 200 patients, about half of them had uterine leiomyosarcoma specifically, and you see here the mix of what was given first was a little bit different, and that allowed them to do a comparison. Even though it was randomized, they could still take a look at, was there any benefit in giving one versus the other first. There was a formal study of this that was examined in the UK that showed that people who got gemcitabine and docetaxel or doxorubicin did about the same when they got that as their first therapy. And even though the numbers are a little bit different here by a month or two, and overall survival is still only, not even a year and a half from this data set. And interestingly, see people with uterine leiomyosarcoma didn't do as well as those who had their leiomyosarcomas arise from somewhere else. In terms of the sequencing of the drugs, since they had this split between who got what first, some people who got the doxorubicin first lived longer than those who got gemcitabine and docetaxel first. That almost reached statistical significance. We use this p.05 as being meaningful, but again, these are not randomized data. And why did people get their doxorubicin first? Did they think that they were more fit than people who started out with gemcitabine and docetaxel? If that's the case, then there may have been some bias in terms of who went first. So I think the data, even though they show some quasi difference here, we do already have the nice randomized trial which shows that we roughly end up in the same place. If you want to believe that these numbers are different, they're 3 or 4 months different. There are some some data from an old study it's already about 25 years old, where we studied in sarcomas just in general, doxorubicin versus paclitaxel. And in that particular trial, interestingly, people did respond to doxorubicin much more than with Taxol, which was studied in that study. And it was interesting that when people got the Taxol first, their response rate to the doxorubicin when they got it second was lower. So we tend to give doxorubicin-based therapy first, and then gemcitabine docetaxel second, at least at our own institution. But it really depends on how fit people are in terms of walking in, and how well we think they're going to tolerate the therapy. So that may account for some of these differences that we're seeing. By and large, we basically have two independent ways of treating these leiomyosarcomas that have some usefulness. So to fill in that hole about the lack of data about pazopanib, there was a study from Italy, Dr. Fabroni and her colleagues, who took a look at 38 patients who were treated at the National Cancer Center in Milan. They have some access to some of these drugs. I don't think it's as much as we have in the U.S., but at least it's something. And these are patients who all had received prior therapy. They had gotten oftentimes 3 different types of therapy, so probably doxorubicin and gemcitabine and docetaxel, and then probably dacarbazine or something along those lines. And when people got this medication, again, kind of like you saw for the other data with doxorubicin or gemcitabine and docetaxel, the response rate was about the same. It was about 18%. It'd be nice if we got out that number to a higher number. But it looked very similar in terms of the frequency of people who were getting some sort of benefit. At the very bottom there, you see again, people stayed on treatment only on average for 4 or 5 months, which is very similar to the study that was done in 2013 to confirm the usefulness of Votrient pazopanib in a randomized trial compared to placebo. And you see here the complications, SAE, significant adverse events. 1 person collapsed their lung, 2 people developed holes in their intestines, which is bad, and 1 person had an obstruction, which may have been from tumor growth more than anything else. But those first 2 things are definitely complications that we see with pazopanib. It's a real drag when they happen because sometimes it will require surgery to fix that problem. And the other thing we don't know is that from cancers that have grown despite the treatment, is that from tumors that have responded and have shrunk and have now left nothing behind to hold everything together, and that's why people develop these perforations. Is probably a little bit of both, depending on the patient. But it's one of those complications that we see with these drugs that it's good for I think for patients and investigators alike to be aware of. I think now here we go. Then the last bit. This is a translational research study to try and figure out why people respond to gemcitabine and docetaxel. This is a study out of Toronto. What they did was, okay, they have a bunch of different samples of leiomyosarcomas. They have the genetics of some of these tumors, and they have the ability to look for proteins in these tumors using routine pathology techniques, immunohistochemistry. And they ran a number of these markers and then started to figure out, okay, well, we've looked at 30 or 40 markers, which ones are associated with people doing well, which ones are associated with people doing poorly. And what they found was that if the cancer looked more mature, this is this COL1A1. COL1A1 is a type of collagen, a connective tissue. And it represents a relatively mature connective tissue. When you found that in the cancer, it was found more frequently in the people who did well with gemcitabine and docetaxel versus those who didn't. These other genes are also turned up either more so in metastatic disease like ROS1, and then some people who had good responses to therapy had evidence of these last markers, IGF-1 receptor, platelet-derived growth factor receptor, and thrombopoietin. When those markers were present, there seemed to be at least some relationship to people doing better with gemcitabine and docetaxel. So this will allow them to begin to stratify who should and should not perhaps get the gemcitabine and docetaxel first versus, let's say, the doxorubicin first. So I thought that was nice work, and will be something they'll be able to continue to work on as they start to fold into this information, the genetics of these cancers as well. All right, so a bunch of new combinations were presented both at ASCO this year in Chicago in June of 2023, and also to a lesser degree at the ESMO meeting in Europe, which was, I think, in September. Some of those combinations were either highlighted again at the CTOS meeting or presented for the first time. And these are some data that Javier has presented before. Javier Martin Broto, he's a medical oncologist in Spain. So this is a Spanish study where the whole country gets involved. Just very early study, seeing if it could combine these three drugs together. And indeed he could, using pretty standard doses of everything. He really didn't have to cut back on any of the medications. And if you go back to this randomized trial that I mentioned, on average, a person getting doxorubicin would stay on the medication for 4 or 5 months before they got worse. And in this very early study with a small number of patients, people stayed on as long as 8 or 9 months. So could be helpful to give everything together. And now is it just a matter of the chemotherapy, or did the nivolumab actually add something? Nivolumab is immunotherapy, as you know, it's a PD-1 inhibitor. So is immunotherapy plus chemotherapy potentially going to become a standard of care? Hard to know. They would have to do a randomized study in which they compared those first two drugs, the doxorubicin and dacarbazine, to these three drugs. And they're just, again, trying to figure out and confirm that the combination is safe to give. And once they do that, they should be able to move on to a randomized trial looking at 2 versus 3 drugs. And if the combination works out better, then that may well lead to a registration for nivolumab for leiomyosarcoma. So we talk about some types of chemotherapy being, quote, immunogenic. Doxorubicin is one of those drugs. I don't really know what that term means. So, but it seems at least there may be some additivity at the very least of putting everything together. A lot of people on the call may be familiar with these medications, or at least that this study is open. This is a drug, a pill form of treatment called unesbulin, which targets the ability of the cancer cells to divide by hitting their so-called microtubules that help to separate the chromosomes. And in this study, this is an early phase study presented by Brian Van Tine and a bunch of colleagues looking at the standard drug dacarbazine, and then adding in lower, medium, or higher doses of this molecule, which helps to block the cells from separating. And in the study, this is about 40 people were treated at different doses of the unesbulin. They all have been heavily treated, and they did see some signs of response. And they also figured out that in terms of side effects, mostly the drop in the blood counts, that the middle dose, kind of the Goldilocks dose for this medication, is going to be 300 milligrams twice a week. And so now there's a randomized phase 3 trial whose schematic was presented also at the meeting as a trial in progress. It's actually done. They put on all the patients that they need, and now it's just being watched for seeing how well people do. So in this particular trial, now that they showed that the combination was at least somewhat useful, 345 people were randomized. 2 got the 2 drugs together. 1 would get a placebo along with the dacarbazine, and then now they're just basically keeping score, seeing how long people stay on these treatments. So we should have information on this trial, I would expect probably by the end of 2024. And again, this is going to be done as a registration trial. They've already presented the form of this study to the FDA and to EMA in Europe. If the sense of being a positive study, it would lead to changing the standard of care, where you would now give the combination of these 2 drugs instead of just the dacarbazine alone, which is the present standard of care, and it's been the standard of care since about the 1970s. Getting on to some of the other combinations that were looked at. Here's a nice study from Dr. Gulnick, who was out at City of Hope, put together a group of colleagues to look at this combination, cabozantinib and temozolomide. And this is, again, the cousin of dacarbazine, that oral version of the medication, which is given at the same time as cabozantinib, which is a cousin of the Votrient or pazopanib that we discussed at the in an earlier slide. And so the temozolomide, it was given at a pretty standard dose, and they also gave a fairly standard dose of cabozantinib to start. The pill version of cabozantinib, that's given every day, and the temozolomide is given 5 days in a row every 4 weeks. And so we do know that there's some usefulness for the temozolomide alone. We also know that there's some activity of the cabozantinib alone from a trial run by Brian Van Tine at Washington University in St. Louis. And in this study, they showed here two cohorts. People had either leiomyosarcoma or something else. And 2/3 had 2 or fewer lines of therapy. So that means they were not quite as heavily treated as those who had gotten some of those other who were put on some of those other studies that we discussed already. But as you see here, 42 leiomyosarcoma patients were put on this trial, and about 5/8 were uterine leiomyosarcoma, so preponderance of those. And you see C1 here, the next to bottom line, response rate was about 17%. Again, and that same 15 to 20% response rate that we've seen for doxorubicin, gemcitabine, docetaxel, and for pazopanib, Votrient. We see that here as well for this combination. And then people stayed on the treatment for about half a year, 6 months. We certainly want these numbers to be longer, but you can see that at least taking a look at these 42 versus the 30 people who had something else besides leiomyosarcoma, people with leiomyosarcoma did better. And that's shown in this particular figure here. This is the so-called waterfall plot. The more the bars point down, the better people did. And uterine leiomyosarcoma is shown in orange in the left-hand figure, and other leiomyosarcomas in blue. And then all the other sarcomas are shown in the right-hand figure, for which angiosarcoma was one of the diagnoses that responded the best in that collection of multiple different sarcoma subtypes. So, is this any better than giving the drugs individually, one by one? Is there real synergy between the two? Maybe, maybe not. I typically would give these medications separately, mostly from the toxicity standpoint of the cabozantinib, but they're able to show that they're able to put the 2 things together. If people get really excited, I guess you could talk about a randomized trial, but one by one, I think also would give you some mileage as well. We certainly see at least some results that are positive like this, although the response rate for the leiomyosarcomas may be a bit better than with either drug alone. So this particular, there's another trial that was presented, and it's EEAAO, which is everything, everywhere, all at once. Why not just take everything off the shelf and give it to people? And this was a study that was done in Santa Monica, where people got low doses of a bunch of different chemotherapy drugs along with immunotherapy, and they treated 17 patients. And again, kind of that same 6 month time before people got worse. And so as a result, there really wasn't any obvious synergy, and it didn't appear to be any better than giving the medication separately. For example, the doxorubicin dose there is very low, and we know that doxorubicin is usually given at a higher dose because it tends to work better when you give higher doses. So, the other problem with a study like this is that, okay, you've given everything, now what? Now you've burned all your bridges, or have you? Oh, well then, okay, if you fail this, then do you go on full dose of doxorubicin? Well, then why did you give doxorubicin as part of the mixture in the first place? So they showed that this was feasible, and yes, they did get some results, but this seems to be a little bit of berry picking, a little bit of this, a little bit of that, without a lot of rationale for putting the things together. We're getting close to the end here. There are a couple of earlier phase studies that were just getting underway as well, and this was perhaps the most interesting of them. This was from Dana Farber, and Candice Haddock and her colleagues are taking a look at this new medication, pepasertib. It's been shown in the laboratory there that it seems that leiomyosarcomas have some dependency on this particular protein called DNA regulated protein kinase, which helps again helps the cells divide. And it turns out that pepasertib is a way to block this particular molecule, and they saw that they could sensitize in the laboratory. They could sensitize the killing of the leiomyosarcoma cell lines with pepasertib if they just added small amounts of Doxil. So they now have a study open looking at the combination of very low doses of doxorubicin with the pepasertib. Now, what's different from the last trial I told you is that they have a mechanistic rationale for doing this, and they're really relying more on the full dose of the pepasertib and then using small doses to try and trigger an anti-cancer response. So I'm curious where this will go. This should end up getting presented, at least some of these data, hopefully by ASCO next year. So that's about 24 slides. We can begin to have a discussion, I think, shortly after this. As you see, these are mostly small studies. The bigger studies tend to be presented at the bigger meetings. There are some interesting leads in terms of the science. As you see, the clinical work remains slow, trying to operationalize some of these findings from the laboratory for the benefit of patients. And I would say that there was at least some evidence here from this second line under clinical work remains slow that you want to lead with your best drugs. If you really do need to get a response, we still typically will use doxorubicin with or without dacarbazine, or maybe with ifosfamide, and gemcitabine combinations. Those still appear to be the two best things that we have as of 2023. And it's nice if you can find a rationale for putting two things together. Why was temozolomide put together with cabozantinib? Well, we know already from kidney cancer, for example, that putting a VEGF inhibitor together with immunotherapy can be a good combination. So people are beginning to use that rationales from other cancers to look at combinations in sarcomas as well. It's worth pointing out that most of the time what we're seeing is an additive benefit, and it's very rare that we see synergy where 2 + 2 = 5 in terms of treatments. So this is why most of the time we will give medications either individually or in known combinations. And maybe the gemcitabine or docetaxel is one example of where there actually may be a little bit of synergy, because we don't see a lot of benefit from docetaxel alone. From that combination, gemcitabine by itself usually doesn't do that much, and so there's at least a sense in some parts that there is some synergy there. So with that, I will stop, and I will stop sharing as well, so we can have a discussion.
Thank you. That was very comprehensive. So I have the first question while people type into the chat box. Which of the studies excites you the most?
Some of those that are coming, actually. There's a new study this is being run by Brian Van Tine and a company that's examining the gemcitabine docetaxel combination with the medication to starve cancer cells, and that study should open next year. Other combinations, such as the use of that cabozantinib with the temozolomide, or some of these drugs like pazopanib, they're drugs like lenvatinib, cabozantinib, and some others that are being combined with immunotherapy. Those are also showing some benefit for people, and the benefit that we're seeing is perhaps more than you would have expected from either the oral medication that's like Votrient or the immunotherapy alone, especially when considering leiomyosarcoma patients. So those sorts of combinations to me look promising. But it's the other good thing is that once these things have been studied, then you've got different choices in terms of trying to walk through these different medications and use them the best you can for given person. If for some reason you couldn't give drug A, you can still give B and C and have those been looked at together. If you have that information, then you can use that with a little more comfort. And even though these studies may only show this sort of additivity of the medications, at least gives us some information that we'll be able to use in the future for specific patients.
Okay, so you have a couple messages in the chat. Do you want to read them?
Did you hear anything about histotrypsy for leiomyosarcoma? I don't know what this means, so no, I don't.
Sorry, it was a question that came from someone in the UK. And it was just,
and it says, okay, here's where they're describing it. Histotrypsy, it says sound waves are administered. These generate gas bubbles within a target tissue, and when the bubbles pop, the shock wave breaks up the mass and it kills the cancer. So this is there's a treatment that's being used for desmoid tumors and some other cancers as well. It's called high frequency ultrasound. That may be one of those approaches that may be useful. I'm not sure if it's just a matter of adding heat to the equation. You can also inject bubbles into people. You can actually do that when we're looking at the heart, but you could also shake up some saline, some salt solution, inject that into the body, and use that same kind of approach to create those shock waves like you're mentioning. So so it's a possibility. The problem is focusing the shock wave. Would you end up the sound waves and so forth end up sort of radiating outwards? It's hard to get them to focus inwards on something. Maybe they can use some crossing of waves or something to get some kind of superposition. But the concern is that you would damage a lot of other normal tissues in the surrounding area with that kind of an approach. So I think the focusing of that kind of approach would be the most difficult thing.
Okay, Laura asked if there's new actionable mutations shown by genetic testing and how are they treated?
Yeah, for leiomyosarcoma, we've tested a number of samples now at our own institution, and there are a bunch of data out there. It's been strikingly little that's shown us a new therapy that you would use based on those mutations that you see. Almost inevitably, we see mutations in a gene called RB or one of its related genes, CDKN2A, CDKN2B at one point, and then the other point is a mutation in a gene called TP53. Those appear to be mutated very commonly, or something very closely related to them in their pathways is mutated in nearly all leiomyosarcoma. So we know mechanistically there's a lot of homogeneity of leiomyosarcomas, even though the specific genes that are involved may be a little bit different. We're still learning about this, and there aren't that many samples that have been analyzed. The best data on that point come from Germany, where they looked at, I want to say it was at least a few hundred people with leiomyosarcomas, and were able to show this consistent change in the DNA fingerprint of leiomyosarcomas.
Okay, how about dendritic cell therapy? Is it effective for LMS?
It hasn't been approved for anything, actually. So dendritic cells are a form of vaccination. Dendritic cells are found in the skin in a network, just a net of these cells. They have their fingers touch each other from the cell bodies, and their job is to respond to a foreign invader, take that foreign invader, engulf it, take it to a lymph node, teach the lymph node cells, the white blood cells, the lymphocytes, what's going on, and then send those white blood cells out to seek and destroy the target that was picked up and sent to the lymph node. So you can do that artificially as well, and but that's considered experimental therapy. So, for example, the closest thing that might be similar to this is a treatment called TVEC in prostate cancer, where they take similar cells and feed them a mixture of prostate cancer cells from and it turns out it's not even the cancer cells from that patient. It's taken from a group of cell lines that exist that they mash up, feed to the dendritic cells, and they somehow were able to get approval for that vaccination strategy even though the data were not that good. So I would still call it highly experimental. With vaccines in general, we have not had a whole lot of luck. Maybe it's something that can be added to the existing drugs that do work. And those are the immune checkpoint inhibitors, blockers of PD-1, PD-L1, CTLA-4, which have approval in a bunch of different cancers. And we're still researching those in leiomyosarcomas and other sarcomas as well.
Okay. Justina wants to know, in your experience, will chemotherapy work for stage 1 uterine LMS and also stereotactic radiation if it works?
So it depends on what you mean by stage 1, because there are two staging systems. There's one that's used by the gynecologists, and if you have a localized leiomyosarcoma and it's gigantic, if it's 4 inches in size, 10 centimeters, it's still stage 1. Whereas in the other staging system that we use for every other part of the body, or most doctors use, that would be stage 3. So stage 1, though, means it's still in the uterus and has not gone anywhere. And the standard treatment for that is surgery, and it's a hysterectomy in that sense. I guess some people have done things like partial hysterectomies, but then you run the risk of cutting through the tumor and spreading the tumor all over the place. That morcellation issue that was a problem, or it continues to be a problem. I think it's the damned device should be pulled off the market for this. But
Right.
only about 1 in 600. There are about 600,000 women who get a hysterectomy each year in the U.S. typically for fibroids, and of those, only about 1 in 600, or about 1,000 women, will have leiomyosarcoma found in that material. But if you're going in there with basically an apple corer, peeling off pieces there, not surprisingly, bits and pieces will stay in the abdomen even if you can't see them very well, and those are the implants that we see grow later. So the devices are still available. I know of a hospital in New York that still uses them, and people have to sign a waiver where they're checking if you might die, you might die, you might die, you might die, you might die. Sign here. I mean, it's just a device that really shouldn't be used. It's a little bit bigger incision. Sorry, you want to get things taken care of. But again, this is just one opinion from a non-surgeon.
I'm very proud. LMSDR actually testified in front of the FDA against the morcellator back in 2013 or 14.
14, yeah.
So we were partially successful, but not totally.
Just a continued education. That's all you can do, I think. So
we still see people on the support group who have been morcellated.
Yeah.
Let's see. Any thoughts about adjuvant chemo for non-metastatic retroperitoneal LMS?
Yeah, that's we don't have any data on that. And generally, I'll tell people that there have been some studies, they're pretty poor, looking at sarcomas in general that occur in the chest, abdomen, or pelvis. And we don't have any data that chemotherapy is helpful to improve the cure rate when you give that chemotherapy. What I tell people is that you may delay a recurrence, and it is possible that there's some benefit there, but whatever the benefit is a small one. This is where some of those initial data saying, okay, who's at the highest risk and things like that, the stuff from Dr. Seng, for example, that may force your hand that way. And the other potential benefit that you might get from chemotherapy in that kind of a situation from a retroperitoneal leiomyosarcoma is, okay, let's say you're destined to have 10 metastases come back in the lungs and you can kill 7 of them off. Well, 3 metastases are maybe something that you can cure, but not 10. So there may be some middle ground there. There's still some people who will take adjuvant chemotherapy after or before surgery for a retroperitoneal leiomyosarcoma or for uterine leiomyosarcoma. But the data that we have that is helpful for people is really, really weak, unfortunately. In fact, none of the data that we have indicates that it's helpful. Doesn't mean it's not the right decision for a particular person. Since it's a relatively data-free zone, I think it's always a point of discussion. I think the most important question that I ask people when we have this discussion after the cancers come out and we don't have data on whether the chemotherapy is beneficial or not is the following question. It's 2 or 3 years from now, the damn tumor came back. Would you be upset in retrospect if you didn't do something, if you didn't get that chemotherapy? And I think that's the fairest way to discuss things with people. You want to get a sense of what their values are and how much risk they're willing to take. And it's really hard to know what the side effects are from these drugs until you get them. So it's a very difficult question to impose upon people. Very challenging, always challenging discussion.
It is a challenging discussion. We just had it in the UK. And they had a different answer, which I kind of pointed out in the States that most doctors want to see a tumor before they give chemo so that they can measure it. But on to the next question about PARP inhibitors. What's your opinion on those?
Well, there are at least a little bit of data on that point, actually, and it's from looking at actual leiomyosarcoma cell lines or samples. There have been some data that show that even if there isn't a specific mutation in leiomyosarcoma, there may be some element that relates them to other cancers that have BRCA1 or 2 loss or mutations. So that's where these other drugs like the PARP inhibitors and the Pol theta inhibitors, which are undergoing investigation now, might be of use. And you can make that, can justify, for example, there was a poster discussing the combination of a PARP inhibitor plus temozolomide. There's a paper in Journal of Clinical Oncology which looked at that question. And yes, there's definitely some activity in women with uterine leiomyosarcoma with those drugs. What was hard to tell from that study, which was only about 20 people, was whether all of that benefit came from the temozolomide or was the PARP inhibitor adding anything to that. Maybe not. It was such a small study, you can't say until either more people are treated or you do a randomized trial. So there's some hints that there are BRCA-like mutation properties within some leiomyosarcomas, whether they're uterine or not. So I think it's a legitimate combination to give to people. It's hard to get it's hard to get insurance authorization for it, at least right now. We'll see what our colleagues say. As you know, there are those NCCN guidelines, which are not the FDA approval, but it's where they get 30 or 40 experts together and vote on the existing data and whether they are strong enough to justify insurance authorization for one treatment or another. That's a double-edged sword. So what if the NCCN guideline crew said, oh yeah, PARP inhibitors plus temozolomide, that should be a guideline listed combination. Well, we only have 20 people that we've treated to tell us whether it's useful or not. And we have no randomized data. And as soon as you put it in those guidelines, the ability to do research is now gone. So because it's going to be very hard to accrue a trial when you can just get the medications by writing a prescription. So, and are the data strong enough or not? That ends up being a topic of debate. Can oftentimes actually, it's even hard getting the temozolomide sometimes, and getting the PARP inhibitors, which are very expensive in comparison, has been difficult.
LMSDR about 3 or 4 years ago, gave a grant to Sujana Mova at Memorial Sloan Kettering to look at PARP inhibitors and see analyze who responds to those. But I haven't had the data come back yet. That'll be really good to know. So
yeah, it's only a small number of people have been treated here, I think. So
yeah.
So there's another question here for the follow-up. I wrote actionable genomic testing, not genetic mutations and treatments. Well, actionable by definition means that there's an alteration that you can treat. So those examples would be things like an NTRK inhibitor or a ROS1 inhibitor, an ALK inhibitor. But that would mean that your cancer had in it already that alteration where the key fits in the lock. And we just don't see that sort of change occurring very often in leiomyosarcoma. So yes, if there is something that's actionable, we do take action on it. But the frequency by which we're finding any of those compounds being useful is very low. It's under 5%. It's probably under 3%, in fact. So, but not zero. So as an example of these, a lot has been made of NTRK inhibitors and use of them in a variety of different cancers. If you look at the Foundation Medicine database, it's 0.7% sarcomas overall that have an end track translocation, and they don't look like leiomyosarcomas. So it's not very common.
Okay. So let's see, we have another question. I have had targeted radiation therapy for LMS to my sacrum bone. My primary is uterine LMS. Is there any evidence of immunotherapy being successful alongside SABR therapy? I'm not sure what SABR therapy is.
I think it's the targeted radiation.
Oh, okay. It should be yeah.
And we don't know. We're seeing, for example, those combinations of drugs like pazopanib. So there's a study of cabozantinib with either nivolumab, the immunotherapy drug, or nivolumab plus ipilimumab, 2 immunotherapy drugs, and either 2 or 3 drugs can be combined and given together. Each of the drugs has some usefulness in leiomyosarcoma, and it would not be crazy to use that as a type of treatment. Again, it's a matter of getting access to those compounds. Nivolumab and ipilimumab are not listed in the NCCN guidelines for leiomyosarcoma, and cabozantinib is not listed anywhere for any sarcoma. It's approved for kidney cancer. So it's hard to get those drugs.
Okay, any other questions, folks? You're going to walk away and say, I have questions.
I think there are still some questions that we haven't managed to
Oh, really?
look at.
Here's
there was
one on pulsed electric fields. Yeah, I don't know much about that. This is something where there's been work in brain tumors where you wear this cap that creates a electromagnetic field continuously. You literally have to wear this thing. You have to shave your head, put electrodes on your head, and apply the electric field 24/7, 365. The idea is you actually freeze they prevent the cells, the electrical fields prevent the cells from dividing as quickly. It provides a force that prevents that. And they're at least, they got FDA approval for that for brain tumors. And I just have not heard of that being used for leiomyosarcoma yet. Would you apply such a device to your whole chest or wherever your metastases are? I just don't know how you would apply the field.
Okay. I'm somehow losing some of the chats. What's the next one?
Then there was another one on any research on ALK fusion in LMS and treatments.
Okay.
Yeah, so that would be one of those targeted targets that we can go after with ALK inhibitors. LMS plus ALK fusion probably isn't leiomyosarcoma. It's probably inflammatory myofibroblastic tumor, IMT. It's a different diagnosis, and we have used ALK inhibitors for people who have IMT. Okay. So yes, we've targeted that particular flavor of sarcoma when it has that ALK alteration.
So Macy asks, from the presentations and debates at CTOS, did anything strike you from those sessions?
Not a whole lot. It was good fun. Just talking about who should be doing surgery and who shouldn't. I thought that was a very germane discussion. You don't necessarily have a sarcoma surgeon or the volume for such a person in every place, but at least they can have some experience. You could be the regional or your hospital's leader when it comes to those sorts of procedures. So I don't think every operation has to be done at an expert center. But you want somebody who's familiar with the diagnosis and has comfort with that. The great question to ask is, well, how many of those have you taken out in this past year? And if it's fewer than 5, you may want to find a different surgeon. But all right. And then the other discussion was on use of off-label or not therapy, and I think it was kind of highlighted by what I just commented on, that you by having too ready access, we may be giving therapies that just don't work very well, and stealing time away from people by giving them side effects from drugs that actually haven't been shown to work as well as they should to garner full approval.
Okay, 2 points for Robin then. He was the one arguing that in the debate. Karen, I'm not sure about your question. Once you've had metastases, what are your chances of living more than a few years? Because I'm going to tell you that really depends on a lot of factors. How about you, Dr. Maki? What do you think?
Yeah, I've had people live more than a decade with metastatic leiomyosarcoma and other people who pass away very quickly. So
Yeah, I would say it has to do
it's
with,
really hard to say.
yeah, how fast,
Rapidity
how
of the growth.
rapid,
Yeah.
how well you respond to chemo. I'm a 21-year survivor. I was stage 4 within a year. So that's a real hard one to say.
Yeah, absolutely. And that's one of the problems we have actually is you can take a look at a leiomyosarcoma, especially uterine leiomyosarcoma under a microscope, and you see a certain number of cells that are dividing and a certain degree of aggressiveness. Well, it turns out that even fibroids look like they're very active under the microscope. And so we end up with this gray zone between benign fibroid of the uterus and actual sarcoma. There's something called stump, which is exactly something in between where smooth muscle tumor of uncertain malignant potential. It doesn't have all the features of leiomyosarcoma, but it doesn't look as, quote, benign, still growing potentially relatively rapidly fibroid. So we have a hard time even saying what the grade or the degree of aggressiveness is of leiomyosarcomas, and this is why some of that research is being done to try and find those markers.
Right. What is your institution's stance on Natera testing? Are there any updates for surveillance strategies?
Yeah, Natera. So this is called circulating tumor DNA testing. This is looking for evidence of the cancer coming back in the blood without having to do a scan. The problem is it's a great idea, but the execution on it, you're trying to find, is truly the needle in the haystack. If there's DNA floating around the blood, it may be just from the normal cells of the body. How do you find something, number one, that's from the tumor, and number two, specific to your tumor in the blood? There are ways of looking for things like that P53 mutation in a blood sample or what have you. But I would call that it's still a research test that's being made available to the public for that sort of analysis. But scans are going to still be, I think, the best way to pick things up. It'd be very rare to find a positive Natera test where you don't see something on a scan. The tests just aren't sensitive enough yet.
Okay, good to know.
Maybe that'll be the case someday, but it would require. I mean, they're already trying to pick up 1 in a million bits of DNA in the blood, and it's a very difficult thing to ask for. But there may be situations where it is useful. I don't want to completely rule it out. But it's just highly experimental.
Justina asks, talking about uterine LMS, what's the role of hormone dependence in the tumor? Any significance in treatment?
Yeah, I just mentioned those stumps, smooth muscle tumor of uncertain malignant potential. If you have a relatively slow-growing uterine leiomyosarcoma, I tend to use hormone therapy first. Some 10 or 15% of women with those will get some benefit from those drugs, and for most women, they're less toxic than chemotherapy. But I have a number of women who've also had horrible joint aches, and that just the arthritic sorts of changes. The drugs just make them feel horrible, and they say that chemotherapy is easier on their bodies than the hormonal therapy. So, but especially the somewhat slower growing uterine leiomyosarcomas, we definitely try hormonal therapy for those women.
We had a webinar last month with Suzanne George of Dana-Farber, and even though her study only had about 7 patients, one thing she did find is grade did not matter. She had people with high grade that did respond.
That's cool.
So and of course it was the higher the percentage of receptors did better, which was, her theory. But I didn't know about grade, so I think that's important to remember. What would be your first line of treatment for LMS that has, originated from the femoral vein and metastasized to the lungs? What would be your first choice?
Yeah, those drugs listed there, dacarbazine and doxorubicin together. If you need a response, then I'll give those 2 together first. If there isn't that much tumor in the body, then there's no synergy between the 2 drugs, and you can give them one at a time. But if somebody had a lot of tumor in their body and I needed to get a response right out of the box, then I would use those 2 drugs.
Okay. Next one we already answered. What's the future of immunotherapy?
It'll probably be given in combination with one of the other drugs, I would guess, kind of an analogy to what's being done in kidney cancer. At least you'd have two additive ways of getting some benefit. The big issue with the immunotherapy is the response rates are pretty low, and they're about the same degree, I would say, as the rate of complications, like bad diarrhea that can get you hospitalized, for example, 10, 20 times a day, or autoimmune attack on the liver. If it's a rash, the immune system attacking the skin, that's usually not as serious, but you start knocking out things like the kidneys or the lungs, which fortunately are rare events, that's a big deal. But it's pretty common to knock out the thyroid with immunotherapy, so people end up permanently on thyroid medication. If you start knocking out other enzymes or other hormones, like from the pituitary, then you may end up on 3 or 4 different hormones to make up for what that organ that no longer exists needs to make.
I see a lot of very specific questions. It sounds like people are asking for medical advice for their situations. I may need to skip those because we can't do that. What are the most dangerous mutations with regard to uterine LMS?
I think it's for leiomyosarcoma in general. It's they're all dangerous because these p53 mutation and either the RB or CDKN2A mutation, this basically lets the DNA keep replicating itself and not stop. Let's say the cell makes a mistake in terms of reproducing its DNA. When you have those 2 bits and pieces missing, that circle just keeps going around and around. I think that's the fundamental problem that we have with leiomyosarcoma. And so any of those mutations, the classic ones that supposedly affect all of these, that's what makes it a bad tumor.
Okay. Is it possible to check why daughter and mother have uterine LMS? Is that your situation, Justina? You have a mother-daughter situation?
If that happens, then yeah, you
Yes,
can
it's
certainly
my
do
situation.
germline testing because sometimes you'll see that happen in the setting of Leiomyosarcoma syndrome. It'd be unusual for it to be the uterus in both people. So, but there are other factors that we don't appreciate genetically. I guess it could happen spontaneously, but yeah, I would at least have sort of have the your a blood sample run for germline testing of the many genes that are now being scanned. It's now 70 to 100 at least that are being examined, whereas it used to be just a handful. So we might pick something up from screening like that.
Okay, great. Yeah, I've seen a handful of families that have LMS. Just a handful, not a lot. Did you have any further conversations with the delegates at CTOS about surveillance? And I can't read it all. Something intervals.
Scan intervals. Changing the NCCN guidelines. Not a lot of discussion on that. It's well covered territory. There's no better way of proposing a scan schedule for people, whether it's I don't know, every 3, 4, 6 months, what have you. We generally will scan more frequently at the beginning of someone's course of their treatment, and if they don't have anything that shows up in the first year or 2, then we tend to slow down. Just trying to match what is the typical pace of recurrence for leiomyosarcomas, which, if they're going to come back, is usually within the first 2 or 3 years. But there's been no schedule that's been shown to be helpful. That doesn't cure more people or help them live longer. For example, we have a hard time even showing that mammography helps women live longer when they get that. So there are some studies in that where, for example, people got scans. It was again for breast cancer. They were getting scans either every 2 months or every 6 months. And then an equal number of people were coming in between scans for a new finding that led to an extra scan on top of that. So as long as people are getting scanned routinely, we're doing what we can. And in fact, if you speak with some of the surgeons, they say, well, you're not going to do anything about it until you get something that's the size of something you can see on a chest X-ray anyway. So why are you bothering with a chest CAT scan? You should just get just an X-ray. So if you're just monitoring that particular site, if you're looking at more, then obviously it's just easier to put people through a CT scanner. But it's just from that lack of proof of any scan schedule being useful than another, that there's broad guidelines there that allow, at least in the US, insurance coverage over a pretty broad span.
Okay, it's 2 o'clock, so I don't want to use up too much more of your time, but we'll just finish with this last one. So Sina said she called your office for an appointment, told you were traveling and not sure when you're going to be available. Are you going to be gone for a long time?
No, I'm teaching in Europe for a week. So
Okay, so you'll be back. So that's good news, because I think you may have gotten a lot more followers here today. So anyhow, thank you.
Sharon, there was
Absolutely.
one question, which was, what's the final message of hope you can offer, not just
Okay.
chemo? I think that's a really good one to end on.
I think that's
Yeah,
an excellent
it's a very
one.
good question. It's a very good question. And the research goes on. Everybody on this, a lot of people on this call are contributing to that research, taking part in trials, or the Count Me In project that's happening through Dana Farber and Suzanne George and the Broad Institute at MIT. So it's kind of baby steps right now, but we're certainly learning more about leiomyosarcomas and all kinds of sarcomas in general. I think this ability to look individually cell by cell has been really a big step forward, and hopefully will teach us how these cells begin to interact with one another. And some of those very basic science slides that I showed you just at the beginning are the first steps in that direction.
Well, Dr. Maki, thank you. It's been wonderful having you talk with us and answer our questions and giving us an update on the research that's out there. Most of it goes over our heads, but I think we can all agree that we feel a lot of hope that there's a lot of science out there, and there's a lot of researchers working towards helping us find some answers. So thank you very much. Let's give them a virtual yay.
Thank you.
Thank you, Dr. Maki.
I appreciate everybody taking time, especially with Thanksgiving tomorrow. So so hopefully everybody has a great holiday, and is able to be thankful for the things that we do have, because we're blessed. So
yes, we are. Okay, thank you so much. Goodbye, everybody.